Okay, thank you. So a little change of gears here. Let's see how it goes. Oops. I do have support from the Women's Health Research at Yale for my research on screening breast ultrasound, and I have no other disclosures. So just to review, we know that screening mammography is the only test that has really shown a clear mortality benefit by reducing the incidence of breast cancer. Multiple studies, the randomized clinical trials performed about 30 to 40 years ago, have shown that there's a 30 to 40% decrease in mortality among women who are screened regularly. And this is mostly due to downshifting of stage 2 or higher breast cancers to stage 1 at the time of diagnosis. And most of these cancers detected on screening tend to be node negative, so there are fewer node negative invasive cancers, and they're less aggressive cancers that are diagnosed with less tumor necrosis and better hormone receptor status. Among screening detected cancers, the 75% of them are early stage 0, DCIS, or stage 1. Among clinically detected cancers, more than 50% are stage 2 or higher. So we know mammography is the gold standard in detecting breast cancer early, but it's an imperfect test, and it's particularly limited by breast density. The sensitivity is as high as 98% in women with fatty breasts and as low as 30 to 55% in women with dense breast tissue. So in these 4 mammograms in 4 different patients who all have breast cancer, the breast density is different, and these are the 4 categories of breast density that we typically see on mammography. So in this woman with fatty breasts, her little cancer is easy to see because there's contrast between the fat and the little tumor. This woman has scattered fibroglandular tissue, and her cancer is easy to see as well. This woman has a 5 to 6 centimeter infiltrative lobular cancer that's really hard to well appreciate because the margins, and it kind of blends in with the surrounding glandular tissue. There's her pathologic lymph node. And in this woman with extremely dense breasts, you can imagine how challenging it is for a radiologist to read these mammograms because the cancers tend to blend in. This 3 centimeter infiltrating ductal cancer we can see for a couple reasons. First, it's palpable, so it's marked by this little triangle. There's an arrow basically pointing to it. And secondly, it's located posteriorly, so there's a little bit of normal retroglandular fat along the posterior breast, so that fat that's dark provides the contrast for us to see this cancer. So you can imagine if this was located more anteriorly, it would be impossible to see. So breast density is important because it limits the mammogram due to the masking effect, and there's decreased sensitivity associated with increased density, but it's also important because it's very common. It's really a normal finding, and about 50% of all women in the United States have what we consider to be dense breast tissue, which is actually 50% or more breast density on the mammogram. There is an increased risk of breast cancer associated with increased breast density. A 4 to 6 times increased risk has been found in women, comparing women with extremely dense breasts as opposed to women with fatty breast tissue. There are also higher interval cancer rates associated with increased breast density, 3 to 18 times increased risk, and we know that there's a worse prognosis in general for the subsequently cancers that are detected clinically. So maybe, breast density, even though it might increase your risk, maybe it's not that important because some people say, well, there's really, there's been some studies that show that there's no increased incidence of mortality. And this study was published a couple years ago looking at the relationship between mammographic density and breast cancer deaths in the Breast Cancer Surveillance Consortium. And they had over 9,000 women who were diagnosed with invasive breast cancer from 1996 to 2005. And although the authors acknowledged that there was an increased risk for breast cancer in women with increased breast density, they also found that the high mammographic density was not necessarily associated with increased risk of death. So this is an interesting study, but it's also, I believe, flawed because you can see that some of the patients in their study were diagnosed in 2005. The paper was written around 2011, so they only had about 5 to 6 years of mortality data follow-up. We know that to get reliable mortality data with breast cancer in particular, you need about 15 to 20 years of follow-up. So I think this is a limitation of this study. Another study looked at breast density and the relationship of tamoxifen, and here they found tamoxifen-induced reduction in mammographic density and breast cancer risk reduction. So in this study, there were over 7,000 women. It was a double-blinded study, and the women were randomized to receive either tamoxifen or a placebo for 5 years. They had a baseline mammogram at the time of randomization and then a follow-up a year to a year and a half later. And there were over 200 women who were diagnosed with cancer at or at the follow-up mammogram. And then compared to the placebo group, they found that the women who had tamoxifen and had more breast density reduction. And those who had mammographic density reduction on their mammogram of greater than 10% had a 63% reduction of breast cancer risk. And those who didn't respond as well to tamoxifen based on breast density, less than 10% response, there was no significant risk reduction in breast cancer. So they concluded that breast density may actually influence treatment options, and believe that changing mammographic density was an excellent predictor for a response to tamoxifen, and there have been several studies that have confirmed this. So again, breast density is complicated, and it might not just be breast density alone. There's a thought that's coming out that I've heard in some of the lectures and other conferences I've been to that might be the complexity of the breast. As mammographers, we know that some dense breasts are a little less busy than others. And one marker of complexity might actually be background parenchymal enhancement on MRI. So with MRI, what we do is we inject contrast, and cancers tend to pick up contrast. And some women have a lot of background normal tissue that takes up the contrast. And they found that actually that increased breast density was not necessarily correlated with increased background contrast parenchymal enhancement, meaning that some women with dense breasts don't have a lot of contrast enhancement. And some studies have also found that MRI background parenchymal enhancement may actually be independently associated with increased breast cancer risk, not just breast density. So dense breast is actually very complicated, and it's really the main reason why new methods are being developed to improve breast cancer screening. Certainly if all women had fatty breasts, there would be no such thing as a breast imager. That's what I do. And anybody could read a mammogram. It wouldn't be very complicated. But it is complicated, and there's issues with supplemental screening that have come into play, such as ultrasound, tomosynthesis, or the 3D mammogram, MRI, molecular imaging, which is what I'm going to get into now. But actually, before I do, I want to just talk about breast density informed legislation. In Connecticut, we passed the nation's first breast density notification law, which became effective October 1st, 2009, so it's been about 5 or 6 years. And since then, 21 additional states have followed suit with similar mandatory breast density informed legislation. Prior to 2013, there were only 4 states with mandates. So the last couple of years have been banner years for the breast density advocates. These are actually patient advocates who have been really working hard to push forth these laws. These laws are not highly supported by the scientific or medical community. These laws are successful due to patients, many of whom were diagnosed with a advanced stage of breast cancer after receiving a normal mammogram. So here's a map of what's going on. The blue states are those states that have passed laws. Pink states are those states as of January of this year that are actively working on laws. North Dakota just passed a couple weeks ago. The yellow states are those states that have passed some sort of breast density related legislation, but the advocates don't think they're really good informed because they don't really inform the patients. There are 4 states with insurance mandates, and actually Connecticut is the only state with a broad insurance mandate for supplemental screening, ultrasound, and has a very good breast density notification law. So there are 22 states with laws, but there actually is no consistency across the states that have enacted these laws. There's variable mention of density as a risk factor across these laws. There's variable notification. Some states, all patients are notified, as we do in Connecticut, versus only those with dense breasts in other states. There's also variable specificity about supplemental screening. In Connecticut, we specifically have to tell our patients about the option of ultrasound and MRI versus a generic more screening that some states mention versus no mention at all about the option of supplemental screening. So as a result of this variability, there's a push by the advocates to have a uniform law across the country. And this could be done either through breast density legislation or regulation. On the legislative front, the Breast Density Mammography and Reporting Act has been introduced every year since 2011 by State Representative Steve Israel of New York and Rosa DeLorio of Connecticut. In 2013, there were 46 co-sponsors. Last year, they didn't get as many, but I was told that's because of the midterm elections. Last year, though, for the first time, the bill was introduced into the Senate, and already this year in February, it was introduced in both the House and the Senate. So they're working hard on that. And if that doesn't work, there's also the option of a regulatory mandate via the Mammography Quality Standards Act, or the MQSA, which actually requires us to give patients a lay letter informing them of their mammo results. And they might just make it that we tell them about their breast density. An FDA panel did approve this amendment, but the final decision is still pending. So there are a lot of opponents to breast density legislation. Like I mentioned, it's really a push forth by patients. The opponents include ACOG. The state chapters of New York and New Jersey and California were very much in opposition. Insurance companies, it makes sense, they've been opposed. Planned Parenthood opposed to it. The Komen Foundation initially against it, but now they're supportive as radiology state societies, including Connecticut. We actually lobbied against it back in 2006 and 2007 and 2008, but then we had to join forces when we knew that it was going to pass despite the opposition of the Connecticut Radiology Society. So here's a statement, a memorandum by ACOG that was distributed in Albany prior to the law in New York, and just call your attention what they say. There it says, ACOG is aware of the intent of this legislation, but we have serious concerns regarding the limited science to provide direction to the patients, their primary care providers, and the breast imagers. And then lower down it says, to date, no clinical guidelines have recommended additional screening solely on the basis of high breast density. So the opponents cite that perhaps the government is overstepping their role in the private physician-patient relationship. They say that there's little data to support the benefit of such legislation, and I'll go into that in a little bit in a few minutes. Maybe we're scaring women without a good solution. They're concerned about the false positives, which I think are overrated. The scaring business makes the breast density advocates a little angry because they think, women should have the knowledge. They also cite, the opponents cite, that maybe we can't provide high quality screening ultrasound to all eligible women. There's also the issue of cost, of course, especially since there's not a lot of insurance coverage throughout the country, which could lead to disparities. And they also mentioned the inexact or subjective breast density determination, which is true, it is a problem. So we determine breast density based on the radiologist looking at the mammogram, which a lot of times is very straightforward. But if you're right in the middle, it's really hard for us to say, like if you're 48% or 52%, and one year somebody's going to be called dense, and maybe the other year the same radiologist could call it not dense. So there's inter and intra-observer variability, which is an issue. There's some computerized modules that are being developed to more accurately determine breast density, but those are fraught with issues and they're not widely used yet. So who needs supplemental screening? I think very high-risk women, regardless of breast density, benefit from supplemental screening with MRI, and that I think is well accepted throughout the country. Certainly less than 70 years of age, it's indicated. High risk is defined as a greater than 20% lifetime risk based on computer modules that predict genetic mutation risk. High risk can also be determined if a woman is a BRCA carrier or a suspected carrier. Also, those women with a history of previous mantle radiation to the chest, usually for lymphoma. These women are high risk for breast cancer if they had the radiation before age 30, and the latency effect of the cancer risk is 8 years. So we wait 8 years and then we screen them early. Over 70 years of age, we do some high-risk screening MRI, but it's probably not indicated. It's probably not cost-effective. There have been little studies that have looked at this patient group, and perhaps ultrasound would be more useful and cheaper. And certainly for those women who can't tolerate MRI, if they have claustrophobia issues or have a piece of metal close to a vital structure, or perhaps in the eye, then ultrasound could be used as well. As far as ultrasound goes, we use it for average risk women with dense breasts. It is an optional screening tool. I believe the patients should be informed of this and they can make a choice. Dense breasts alone is an intermediate risk factor. It is controversial, and the American College of Radiology prior to 2011 didn't even list ultrasound as an option for screening for breast cancer in their appropriateness criteria. Currently, though, they just say that it's indicated for high-risk women who cannot tolerate MRI and suggest it's an option for intermediate-risk women. Okay, so let's just talk about screening breast ultrasound. Screening breast ultrasound is the most widely used supplemental screening tool in women with dense breasts, and it's been around for a long time. 20 years ago, the first paper was published in Cancer by a group in Canada that showed that in women with dense breasts and a negative mammogram, the supplemental cancer detection rate of ultrasound was 2.4 per thousand. In 2008, there was a study published in JAMA. This is the Akron, the American College of Radiology Investigative Network. The Akron 666 study was a multi-institutional study that looked at women with dense breasts, a negative mammogram, and one additional risk factor. It was a landmark study and showed that the supplemental cancer detection rate was 4.2 per thousand. So in addition to these two studies, there have been numerous studies throughout the years, and this is a busy slide, but in the bottom, it basically shows that across the studies, it's been pretty consistent that the supplemental cancer detection rate of screening ultrasound is 3.4 per thousand. And you might say that's really low. Why are we doing all this for 3 cancers per thousand? But remember what the cancer detection rate is for mammography screening is about 2 to 7 per thousand. And that's well accepted that, we should do it. In general, it's well accepted. And so screening ultrasound is right in that ballpark. The difference, though, is that with screening ultrasound, you can see down here that the positive predictive value is pretty low. It's 10% or less across these studies. The positive predictive value for mammography is between 25 to 40%. So that's one of the sticking points with screening ultrasound. There are some advantages, though. It's widely available. Just about every radiology office has an ultrasound unit. It costs about the same price as a mammogram. It's well tolerated by the patient. There's no safety concerns. There's no radiation or IV contrast. There was a study published last year that looked at breast cancer detected with screening ultrasound and the reasons for non-detection at mammography. So this study basically shows that screening ultrasound can detect cancers that mammography misses. So there are over 100,000 screening ultrasounds and 335 cancers diagnosed with ultrasound. The cancer detection rate was 3.4 per thousand. And they looked at these cancers and found that nearly 20% were seen on the mammogram and were missed due to interpretive errors, because reading mammograms is difficult. But the majority, 81%, had no abnormal mammographic findings, even in retrospect, so it's showing that we can pick up these cancers. Now, I think it's really interesting. I don't know if you guys picked up on this, but there were over 100,000 screening ultrasounds in this study. This is a huge, study population here that they were able to look at. And they were looking at them from 2003 to 2011. And that's because in Asia, particularly in Japan and South Korea, where they have formal breast screening programs, they've been doing screening breast ultrasound for years without controversy, unlike here in the United States. And why is that? I'm not really sure why, but I do know that even though the rate of breast cancer is lower in Asian women compared to women in Western countries, the rate of having high breast density is much higher. About 70 to 80% of Asian women have dense breast tissue. So they've been screening with mammo and ultrasound without controversy. Okay, so the disadvantages of screening ultrasound: there's limited ability to detect DCIS, which usually presents as microcalcifications, and those are hard to see with ultrasound. It's time consuming, there's operator dependency. Again, that positive predictive value is low, which leads to increased benign false positive ultrasound biopsies and increases healthcare costs. One of the really important disadvantages, however, is that there's no proven long-term mortality benefit to women. And that's because no randomized clinical trial has ever been performed for screening breast ultrasound. To do that would be impossible today for a bunch of reasons. It would be hard to randomize patients. It would be too costly to do. We couldn't afford it. And importantly, technology just changes too fast. Remember I said that it takes 15 to 20 years to get good mortality data? We can't wait 15 to 20 years. By 15 to 20 years from now, who knows how we'll be screening, the way technology changes. And importantly, we want our information immediately. We have our smart devices. We want the answer right away. And the public just can't wait 15 to 20 years for a randomized clinical trial. So we have to do something else. Nevertheless, we know that most cancers detected on screening breast ultrasound are invasive. Less than 1 centimeter inside is a node negative, so it's rational to believe that finding these mammographically occult cancers at an earlier stage and a smaller size will improve overall mortality. So here's some example of some of the cancers that we've detected in women with dense breasts and a negative mammogram. And you can see with ultrasound, the dense breast tissue is white or echogenic. The cancers are dark or hypoechoic, so we have the contrast where we can detect these cancers. So what about the 3D mammogram or tomosynthesis? I'm asked this question all the time. If we're doing that, do we need screening ultrasound? Because with tomo, we catch more cancers, and we all see in the billboards on I-95 that it's better. Certainly with screening ultrasound or tomo, they will both increase the cancer detection rate in addition to conventional 2D full field digital mammography alone. And both will catch small invasive cancers, but they're different. Ultrasound is 2 exams for the patient. It's primarily reserved for women with dense breast tissue, and the positive predictive value is low. With Tomo, in addition to the conventional 2D mammogram, although it's two separate tests, it's really perceived by the patient as a single exam because it's done with the same compression at the same time. We offer it, and it's been shown to be beneficial for women across all breast densities, and the specificity is higher with fewer recalls, fewer false positives on the screening mammogram, and the positive predictive value is higher. So certainly the cost effectiveness of ultrasound will decrease with tomosynthesis, but not completely. We did a study at Yale a couple years ago, and we're expanding our data because we have a very unique environment where we do a lot of screening ultrasound and we're fully tomo here. So we're way ahead of the rest of the country. And in our initial data, we had over 1,000 women who had both screening ultrasound and tomo with dense breasts. And we found that the supplemental cancer detection rate decreased by about 40%, from 3.2 per thousand before we had tomo to 1.9 per thousand afterwards. But the negative predictive value was 100%. There were no interval cancers. And that's very important because we can't do randomized clinical trials. One very good surrogate marker for, I think, the success of a screening program would be to look at the interval cancer rate, because that could just take a couple years to find. So in our experience, we know that ultrasound will detect slightly more cancers than tomo. Here are some cancers that we have detected on ultrasound that were missed on tomosynthesis. And with tomo, I don't know if you can see here, but it basically gives you slices through the breast, and we scroll through, and that's why they call it a 3D image, because we scroll through it. But those are negative. Okay, so I don't tweet. I don't know how to tweet. I have no interest in tweeting, really. But I received this tweet by email in January from the nurse oncology advisor. And it says, supplemental hashtag breast cancer screening with ultrasound may not be the best option for women with dense breasts. And they're referring to this article from the Annals of Internal Medicine. So what's that about? So this was published last December, looking at the benefits and harms and cost effectiveness of supplemental ultrasound screening for women with dense breasts. This was a multidisciplinary team, including some very prominent radiologists who I respect. But basically, what did they find? They did a theoretical modeling of ultrasound after a normal mammogram in women in their 50s to age 74. And they found that screening ultrasound in these women with dense breasts would substantially increase costs with relatively small benefit. They suggested that screening every other year or only screening women with extremely dense breasts would be more effective. And they also went on to say that perhaps breast density legislation should be evaluated from variable perspectives. Well, one thing, breast density legislation, that cat is out of the bag. It's probably going to be a national law sooner rather than later. So that's not going away. But when I looked at the paper carefully, I saw that what their theoretical modeling was based on the Akron 666 study. And when you publish it, when you have data, there's always a range. And I think that they picked the lower range for the ultrasound cancer detection rate and things. So basically, I think they underestimated the benefits and overestimated the harms of screening breast ultrasound. And that's what also the authors of the Akron 666 study believe. So what about screening MRI? I said that it's good for women with who are very high risk, but there is growing interest for using screening MRI for average risk women with dense breast tissue. I know my colleagues at University of Pennsylvania, where they have the breast density notification law, they're trying to steer their patients away from ultrasound and doing a fast MRI screening. That's also true at the University of Washington. So Christiane Kuhl is a very prominent, world-renowned breast imager in Germany, and she developed this fast MRI protocol and published her results in the Journal of Clinical Oncology last year. And she had over 600 exams in women with dense breasts and a normal mammogram, and they were not high risk. It was a fast protocol. It only took 3 minutes, so quick in and out. It does require IV contrast, and it took the experts about 3 minutes to read the exam. So that's sort of equivalent to a mammogram, because you have to read a lot of them fairly quickly. And look at that supplemental cancer detection rate, 18.2 per thousand, so much higher than mammography, which could be as high at best at 7 per thousand, or screening ultrasound, which is 3 to 4 per thousand. They followed these patients for a 2-year validation period, and there were no interval cancers, so the negative predictive value was nearly 100%, and the specificity was good. So here's an example of some of the MRIs that she took from her paper, and there's questions about doing this or widespread availability. Is there enough MRI scanners and high quality MRI being performed to offer this to patients? There's also issues with insurance. Even though the price would drop compared to a conventional MRI, it would still be a couple $100 dollars, so more expensive than mammography and ultrasound. Also, for those people, and I tell this to my colleagues who don't like screening ultrasound and want to do MRI, remember, MRI doesn't work for everyone. And the Akron study was well designed because after 3 rounds of mammo and screening ultrasound, the patients were offered an MRI for free. And at the end, there were over 1,200 eligible women, but 42% declined MRI. Remember, these were highly motivated women in the study. They signed up to do the Akron study, and they went every year for their ultrasound. The reasons: 25% said claustrophobia was the issue, 18% time constraints, 12% financial concerns, not sure why, even though it was free. And then there were other issues. The PCP didn't think it was necessary, or the patients weren't interested, or there were some concerns about the IV contrast. So finally, another option, there's some interest in molecular breast imaging as well as a supplemental screening tool. There was a paper published in one of our radiology journals earlier this year that looked at MBI and low-dose technetium sestamib in over 1,500 women, and they found that the supplemental cancer detection rate was very good, 8.8 per thousand. The recall rate bumped up a little bit, so the specificity dropped down a little. But they did propose biannual mammogram alternating with the MBI screening. So I think this is an interesting study because it's starting to say, hey, maybe we should think out of the box. Maybe we don't need to screen every year. Every other year, as the United States Protective Services Task Force says, after the age 50. But maybe we can alternate that with one of our supplemental screening tools like ultrasound, MRI. I'm not sure which one is going to win out in the end, and it might be a combination based on what the patients want. We have to remember that in general there's a major shift in medicine because we're now in an era of patient rights and empowerment. We live in an information society and we have to be proactive to this movement. Patient education is key. There's a series from CNN Health, When a Mammogram Isn't Enough. It's kind of old, 2010, so I had to update it. Didn't take me long. I was in the supermarket and I found this issue. It's a medical tabloid right next to People and Us magazine, so I kind of wish I didn't zoom in on it. But it was there. What doctors don't tell you is this magazine, and of course the front cover, mammograms, what they're not telling you. We have to educate our patients. We have to educate the referrers because I think a lot of them are uncomfortable talking about breast density and supplemental screening. There is a new website that just came out a couple weeks ago, densebreastinfo.org. It's, I think, a fair, balanced, and organized FAQ for women and healthcare professionals. So that's a good resource. What we want to avoid is the statement by ACOG, their FAQ on dense breasts. Second question, did dense breasts mean I could have breast cancer? The answer, all women are at risk for developing breast cancer regardless of their tissue patterns. And that's just not telling the full story. I think women deserve a little bit more of discussion. Certainly, regarding breast density and legislation and screening, more evidence-based research is needed. We need to assess outcomes, improve our results, which we have been doing in our practice. Our specificity has started out less than 10%, now we're at 20%. We also need to work together. All parties have to work together and reach a practical consensus. Legislators, patient advocates, the American College of Radiology leadership, the Society of Breast Imaging leadership, ACOG, the American Cancer Society, and the American Society of Breast Surgeons. We really just need to work together and not just stick our heels in the sand and say my way is the only way and the right way, which is kind of what some people do. We have to remember a one-size-fits-all breast cancer screening protocol no longer exists. Women should be aware of the increased false positives and negative results with screening. And we have to remember that screening ultrasound will increase the cancer detection rate by 50 to 100% actually. And patients do have a choice because really in the end, the fact is all medical screening tests are optional. So thank you.